In my daily clinical activity, I always try to personalize the treatment for each single individual patient. And this means that I have to select what GnRH analog to use. You have to choose between GnRH agonist or GnRH antagonist, but you also have to choose between different types of gonadotrophins, and most importantly, you have to select the FSH starting dose. When you have to choose the treatment for patients, you have to consider all clinical characteristics of the patients, including the clinical history, previous IVF cycles, and most importantly, you have to look at the body weight, to the menstrual cyclicity, and most importantly, to the ovarian reserve of these patients. For many years, we have used female age and day 3 serum FSH to predict ovarian response in IVF. More recently, we have introduced serum AMH and the antral follicle count. The real advantage of these two biomarkers is that they have a linear relationship with the whole spectrum of ovarian response, from poor response to hyper response. While serum FSH was not able to identify those patients at risk of ovarian hyperstimulation syndrome, serum AMH and antral follicle count, well, they have a very great diagnostic performance in predicting the two extremes of ovarian response. Our group recently showed that a combination of biomarkers may increase the predictive ability of clinicians. So you may use female age plus serum FSH plus AMH plus antral follicle count to improve the ability to correctly identify patients at risk of poor response or hyper response. That's important from a clinical point of view, because the more accurate the predictive ability, the more appropriate the ability to personalize the treatment. In particular, we have published the formula that is based on female age, serum FSH and the AMH, and that can help clinicians in choosing the more correct FSH starting dose for each individual patient. What's important now is that this formula has been tested in a randomized controlled trial, recently published, and the primary outcome was the proportion of women with appropriate ovarian response, with a normal ovarian response. And in this trial, it was showed that the use of this formula to personalize the treatment was associated to a significant increase in the proportion of women with a normal ovarian response, hence reducing the number of patients exposed to some risk following ovarian stimulation. In the past, we mainly used fixed doses of gonadotrophins in our IVF patients, or sometimes we just looked at female age. Just to give you an example, we used to treat patients younger than 35 with a fixed dose of 150 units, or we used 225 units in women above the age of 35. But this is not completely correct, because, as I said, ovarian response is largely dependent on ovarian reserve. So in the clinical practice, you may have young women with a very poor ovarian reserve, or aged women with a very high ovarian reserve. This means that this patient will be at risk of OHSS if you are going to use a maximal ovarian stimulation. That's why you must personalize the treatment. And to personalize the treatment, you have to measure ovarian reserve for each single patient. And to do this, you have to use the best markers we now have in our hands, the image or the ultrafollicle count. AMH and ultrafollicle count are widely used in the clinical practice, and very recently we have published an Italian survey for the use of ovarian reserve biomarkers in IVF clinics, and we saw that 89% of doctors, of Italian doctors, are currently measuring the biomarkers, AMH and or ultrafollicle count in all women entering the IVF program. And when the doctors are asked, why are you measuring ovarian reserve biomarkers, they answered just to personalize the treatment in IVF, or because they are measuring the biomarkers because they want to prevent ovarian hyperstimulation syndrome, because they think that this may lead to some improvement in the clinical performance of their IVF program, or to reduce the patient dropout.